Good morning, everyone. Today I would like to present on SIJ or sacroiliac joint dysfunction. So basically, sacroiliac joint dysfunction is the degenerative condition of the sacroiliac joint that is resulting in the low back pain. Incidence is actually poorly estimated. The prevalence is like about 15 to 30% of all the low back pain in the outpatient settings. The reason why is the prevalence is poorly estimated is because of the complex multi-structural anatomy of the pelvic joint, the SI joint, as well as the multifactorial nature of the lower back pain itself. So the etiology of the SIJ dysfunction can further divided into three, which is idiopathic mechanism, intra-articular and also extra-articular mechanism. However, the idiopathic mechanism actually is the commonest cause of the SIJ dysfunction. It's hypothesized to be because of hypo or hypermobility of the SI joint, and it could be because of the capsular tension and also shear force towards the SI joint. So intra-articular mechanism actually includes inflammatory reaction that is result in the formation of the subchondrosis, sclerosis, osteophyte formation, as well as ankylosis. So in inflammatory cause, commonly around almost 100% of patients with writer's syndromes and also ankylosing spondylosis will have SIJ dysfunction. Infection wise, usually because of the bacterial spread from the blood stream, and metabolic cause is because of the conditions such as gout, calcium crystal deposits, and also hyperparathyroidism, and also metastatic tumors to the SI joint. Next is the extra-articular mechanism of the SIJ dysfunction. It could be because of the entisopathy, which is caused by inflammation of the ligament that attach to the SI joint. Insufficiency fracture often occurs in adult with pathological osteoporotic fracture that can result in the SIJ dysfunction also, and also post-traumatic due to pelvic ring injury. Anatomy of the SI joint actually is quite complex. SI joint is basically a large, flat, partly fibrotic and partly synovial joint. So the joint articular surface is around 17.5 cm. The muscle that attach around this structure is gluteus maximus, gluteus medius, rectus femoris, latissimus dorsi, erector spinae muscle, as well as the internal and also external oblique muscle. While the ligament that attaches surrounding this structure is actually anterior joint capsule and also ligament, posterior interosseous ligament, sacrotuberous ligament, and also sacroiliac ligament. Innervation wise, the anteriorly is innervated by L2 to S2, ventral rami of the sacral plexus. The posteriorly innervated by L4 to S4, dorsal rami of the sacral plexus. Symptoms of SIJ dysfunction: commonly patient will complain of deep, diffuse pain in the buttock, usually unilaterally, and sometimes it can radiate until upwards, but less common, more than above the level of L5. Also can radiate towards the knee and also the foot, aggravated by activity that increase the load to the SI joint, for example sitting, walking, and also lumbar spine movement. In the physical examination, we can elicit tenderness at the sacral sulcus as well as around the area of the posterior superior iliac spine. We can also perform few provocative tests, but there's no single provocative test that is diagnostic of SIJ. So usually we will need 3 or more positive provocative tests in order to establish a diagnosis of the SIJ dysfunction. So among the tests that we can perform is Faber test, flexion, hip flexion, abduction, and also external rotation. 14 finger test, whereby patient will point twice to the area around the inferior medial to the posterior sacroiliac spine. Gensler's test, SI compression test, SI distraction test, anterior sacral thrust test. And SLR usually is negative, but it can be positive if the leg is brought more than 60 degree because of the increase in the SI joint motion. So the differential diagnosis for the SI joint disease could be any hip pathology, hip labral tear, hip osteoarthritis, degenerative disc disease, lumbar disc herniation, lumbar spine stenosis, and for the investigation we can perform X-ray, pelvic X-ray, epilateral and also SI joint view, and the findings usually we can see there's a subchondral sclerosis, osteophyte formation, ankylosis, and sometimes we can do MRI, but actually not to diagnose the SI joint disorder, is because sometimes we can exclude other differential, for example tumor and also any infectious process. Treatment divided into non-operative and also operative treatment, but I will focus to the non-operative treatment, usually further divided into 3 lines of non-operative treatment. The first line is NSAIDs to reduce the inflammatory process associated with the pain, the lower back pain, and also some physical therapy. We can do soft tissue massage, joint manipulation, and also joint mobilization. We can apply a pelvic belt around the greater trochanter to limit the motion of the SI joint. We can teach the patient some core muscle strengthening, proprioception, and also flexibility exercise to correct the lumbar pelvic and also hip biomechanics. Second line, we can actually the first line treatment is recommended to be planned minimum for 4 weeks before we can proceed to second line treatment, which is steroid injection. So SI joint steroid injection usually we do under fluoroscopy guidance, or it can also be done under ultrasound guidance. But the accuracy, 98% accuracy if we perform under fluoroscopy guidance. So 60% success rate at pain relief until 6 months post injection, more than 75% reduction in the SI joint pain after the first injection. But it has a quite lower success rate in the patient with a previous history of lumbar fusion. And SI joint steroid injection actually to be performed around 3 times in a period of 6 months, or not more than 4 times in a period of 1 year. Third line is radiofrequency ablation, targets on the lateral branch of the sacral nerve root, and actually there's also a role of prolotherapy by injecting mixture of sugar, dextrose, and also local anesthetic. Actually targets to generate inflammatory response, fibroblastic process, and also scar tissue formation to further stabilize the joint, but the role is a bit controversial. So lastly, operative treatment for SIJ dysfunction, they usually will perform SI joint arthrodesis. That's all.